Okay. Welcome, everyone. For those of you who don't know me, my name is Brooke Levy. I'm the Executive Director of the Down Syndrome Network of Montgomery County. Um, Tonight's speaker series is on co-occurring diagnoses in Down syndrome and in the Down syndrome community, part one. This is a three-part series, and our first speaker in the series is Dr. Mary Pippin, and I will be introducing her in just a moment. Um, if you haven't noticed in the last several months, we truly are serving people with Down syndrome from birth to adulthood. We've recently hired a youth program coordinator. So that kind of rounds out our age groups because, as you know, we have Christy Meng, who's coordinating our new family and medical outreach program. And then we now have Dion Cheatham, who is coordinating our youth programming for ages 5 through 13, sometimes overlapping with our transitioning youth and adult program manager programs. With Jen Emmel, who works with our members who are 14 and up. And so I just wanted to let people know that that's something that we're really trying to let people know and offer more programming. And as you know, we're not just serving folks in Montgomery County. We've become much larger than that, and we're now serving folks in Washington, D.C. and the surrounding counties as well. And I can see folks who are in here are who are from the surrounding region as well. Just some upcoming events, and I can put the link in the chat in a little bit. We do this weekend have Papusa Day hosted by our Grupo Latino. We have our monthly youth meetup. Now that's new. We used to have the play group that was just for the littles, but this, because it's nice out and we can meet at outdoor playgrounds, we are extending this from our 0 to 4s, but all the way up through 13-year-olds. And Dion and Christy will be at those events. We are also, if you haven't been to one yet, on the months that we do not have our mom's night out, we have our Parent Connect. Our next one is coming up on May 4th, and that will be for any parents who would like to come and connect with each other to help navigate any aspect of your life as a parent of a child or adult with Down syndrome. We have our We Rock the Spectrum outing coming up in May as well. And of course, please put on your calendar. The registration is opening soon for our summer picnic. And then, of course, this summer we will have our outdoor splash park and mini golf. So I will make sure that I will put some um, links in the chat this evening so that you have access to all of those. Um, just some housekeeping. Please stay on mute during the presentation. This webinar is being recorded and will be made for viewing afterwards. We try to do that within 2 weeks. We'll do our best. Um, Q&A will take place after the presentation. You feel free to ask questions in the chat as I will be monitoring them throughout the presentation and afterwards as well. And then at the end, I will put this link in here for our presentation evaluation. We really rely on these so that we can improve what we offer and then also just offer programs that you're interested in. You have the opportunity to put topics in there. So with that, I just would like to welcome Dr. Pippin. She is a developmental behavior pediatrician at CHOP, which is Children's Hospital of Pittsburgh. And
Philadelphia.
oh, sorry, Philadelphia. Oh my gosh, I don't know where I was getting that. Philadelphia, and the director of the trisomy program there. She is a board certified developmental behavioral pediatrics and general pediatrics, and the mission of the Trisomy 21 program is to provide guidance to families on medical, developmental, and behavior care in order to optimize the well-being of individuals with Down syndrome so they can flourish as members of their family and in the communities. So this is right up our alley, as you know, with DSNMC. It's a very similar mission. And so we're very excited to have her. The clinic is multidisciplinary with 3 developmental behavioral pediatricians, a nurse, and social workers, OTs, PTs, and speech therapists. So this is truly a Down syndrome clinic, and probably the closest one for us, living here in the DC area. Uh, in her clinic, they help families coordinate medical care, advocate for behavioral support in the community, and needed educational support. The clinic also has collaborated with researchers to further the knowledge and improve care in the Down syndrome community. So with that, I would like to welcome Dr. Mary Pippin, and she's going to have a slide deck that she's sharing. And so welcome, Dr. Pippin.
Hey, thanks. Let's see.
And let me know how I can help you.
Marty
Oh,
Clark,
look at that.
do some
You got it.
cartwheels.
Oh, let's see.
I think it's
Yeah.
Yep, that looks like it. Okay.
Awesome.
Okay. Slideshow, that's usually a good place to start. Where's start? Play from start. There we go.
There you go.
Privacy window, picker, and directly access your screen. Sure. Okay. You never know what you're saying sure to, right? Wait, no, that's not it. Sorry, that's not it.
That's okay.
Wrong one. I'm sure you would like to hear this one too, but okay, let's see. End show. All right, let's see. I have a few Moncoa co-occurring editions. I make this is the whole one. Yep. Okay. This may work. Let's see. Slideshow. Now I know where to navigate from.
Great.
Yes. Okay. So hi, I'm Mary Pippin. I'm the director of the Trisomy 21 program at the Children's Hospital of Philadelphia, and a developmental and behavioral pediatrician here at CHOP. And I titled this Individuals with Down Syndrome, Wonderful, Amazing, Unique, Diverse, and Complex Who Happen to Have an Extra Chromosome. These were the goals of the talk that I was given, and I was like, oh, that will take about a week or two. So what I decided to do is just to go with the co-occurring diagnoses that I see most in my clinic that are most problematic for the most people. And some hot topics as well. Well, one hot topic. So, and then recognize behavioral, developmental, emotional flags that may warrant further evaluation, which I'll kind of include in their different places. And then define your concerns and be sure you are heard. I think that's related to really, as you guys know, whenever you're talking with any of us from the medical profession or from the educational angles or wherever, if you don't make yourself heard, you don't get heard. So, and we try to empower parents to make themselves heard. So the Trisomy 21 program at CHOP, we began in 2003 with Buddy Walk funds raised by a local parent group. And related to this talk, I was corresponding with Matt, and he said he was from Montgomery County. And I said, okay, great, because Montgomery County here in Pennsylvania was the initial donor. They were the group that brought the money. And my nurse coordinator, Trisha Wilson, said to me probably on maybe Monday, or she said, you do know that that's not Montgomery County, Pennsylvania, right? And I was like, really? Thinking that I was going to be just traveling up the road to give a talk. And she read the email much more closely than I did. So, but anyway, so we went from 2003 to having 2 patients with our first clinic and a physical therapist and myself, to having over 2,700 patients from prenatal visits through adulthood. We have a multidisciplinary team with MDs, a nurse practitioner, our nurse coordinator is an RN, soon to get another nurse practitioner on board, a physical therapist, OT, speech, and social work. And we're up to about 13 provider days per month. Again, down from 1 per month when we started. And we have well over 700 patient visits per year. So why does trisomy 21 cause so many co-occurring conditions? And the 21st chromosome is the smallest human autosome, but it does have a lot of components. So there's 33.8 million base pairs. And what gives somebody trisomy 21 is the longer arm of, and if you don't know all this, if it seems medical jargon, I apologize, but the long arm of the 21st chromosome has over 350 genes. 145 of those, maybe a little bit more now, have functions that we've identified, and a large array of functions. And we've learned a lot about Down syndrome through mouse models that replicate T21, and also through organelles, which are grown from stem cells into organelles, brain organelles, and figuring out how cells in developing these developing organelles, how they're different from cells that, or from organelles that don't have trisomy 21. So anyway, these genes affect gene functioning on other chromosomes, right? So it's not only the T21 chromosome, but the triplication means that you're sending out more protein signals, and those signals affect every other gene, every other chromosome in the genome. So it's a really complex disorder, and each child has the genes from mom and dad too. So every child, all your children with Down syndrome, have more genes from you and your spouse, and are more similar to their brothers and sisters than they are to other kids with Down syndrome. Okay. And the T21 extra genes, they can affect every body system, not all equally, so which makes everybody very different and unique. And they can affect all the different systems of the body.
Did you do some cartwheels? How many? You need to do 5.
Okay. So, and lessons we've learned over the past, 23 years now, is one, children first. So we've learned that you have to see kids with Down syndrome as kids first, and adults as adults first. Listen to caregivers and what they say. They know kids the best, or they know their adults the best. Support each person as an individual, and meet families where they are and guide them on their journey forward. When I first started, I think I did a lot of dictating and telling people what I knew without recognizing that they weren't there, and needed to kind of do an approach that was a little bit different. And then acknowledge caregivers' efforts and support, because it's a really, really hard job. Okay. The other thing that being in the kind of Down syndrome sphere is, and other genetic disorders, is recognizing that there's such a strong link between health, development, and behavior. And so really realizing from the get-go that we couldn't just be developmental behavioral pediatricians. We really had to look at health issues. And so probably we spend as much time on medical issues as we do on developmental and behavior. And we spend much more of our coordination time coordinating with other medical subspecialties at CHOP on the care of our patients with Down syndrome. Okay, so again, kids first. The other thing is and this is what I love about what I do, is that I get to be a real doctor. Because of the medical complexity and the developmental behavioral complexity, you really have to pay attention and you have to be observant. It's just so much fun to go into a room and you're just observing everything, from how they're breathing to how they're walking to whether they look at you or not, to how they're engaging with their parents and other people in the room. The other thing is that we often hear still, unfortunately, that, when a parent brings a complaint to a provider, the provider says, well, you do know they have Down syndrome, right? Which is like a lot of things wrong with that. But a lot of people think, well, if you have reflux, well, you have Down syndrome. So reflux is part of Down syndrome. Whether it is or not, you have to still address it and you have to still treat it. The other thing is that there's similar risks of other disorders as just as in the general population. So if, we had, when I first started, had a little boy who was about 15 months old, wonderful, beautiful child, but he had stopped pulling to stand. He just moved like a snake on the floor, very weak. And the person who referred them to me said, I know kids with Down syndrome have really low tone, but this is different, I think. And I looked at him and I said, yeah, it's way different. We sent him to our neuromuscular clinic, and he also had spinal muscular atrophy. And that was just from 2 genes inherited from his parents, unrelated to Down syndrome. So that brings me to, so they have the same familial risk factors as well. So, you really it keeps you on your toes as a treating physician. And so, again, when I just was thinking about how do I fit the co-occurring conditions into a 30 or 60-minute talk, I thought, well, I'm just going to really start with just the things that I see the most, that are the most problematic in clinic. And so the most problematic medical problems that we see, and we see kids again from babyhood, so like 5 or 6 months, all the way up through adults. And so medical issues, feeding, nutrition, obesity, GERD, constipation, and sleep apnea. And as you could tell, the first 1, 2, 3, 4, 5 have to do with GI. So GI is a big deal, common big deal, and then sleep apnea. And some of the photos that you're seeing here are from our annual Buddy Walk, which happens in October at the Lincoln Stadium, the Link here in Philadelphia. So feeding. So when we first started clinic, right soon after we started clinic, we got a grant to study growth charts, or to build growth charts for US kids with Down syndrome. And so in order to do, part of that was we needed babies. So we started Baby Day. And so we have 2 baby days a month now. And we have a feeding therapist that's part of our team on those days. And so we've learned a lot about feeding and babies. And so one of the issues initially early on, and sometimes with older kids as well, is chewing and swallowing. And so when we're looking at kids in baby clinic, our feeding therapist always watching them feed. We're listening to them breathe. We're listening to how junky they sound. And deciding whether we need to do further investigation. So part of it is trying to figure out if they need a swallow study, which many more kids should be getting than do. The other is to follow their weight closely, because if they start dropping off the curve, that's an indication that they may be having trouble, and whether they need supplements and whether they need tube feeding. And then the other piece to do with feeding is selective eating. So I'm sure many of you on the call have kids that don't eat everything that you put in front of them. And so if selective eating is pretty selective, then we get nutrition consult and nutrition labs if indicated, and then advocate for slow, steady introduction to new foods, but also getting back to the chewing and swallowing thing, figuring out if they need supplements to adequately grow. Because, getting adequate nutrition and getting adequate nutrition for brain growth as well as body growth is kind of your eyes on the prize with kids growing up. The what was I going to say about that? Not sure. Anyway, the other thing that we see is eating too much. So when you look at kids with the growth charts of kids with Down syndrome, you start seeing weight increases relative to height, probably around 2.5. And if I'm seeing kids that are crossing percentage lines, I'm talking to them about feeding and limiting feeding, even as young as 12 months to, around that age. Some kids we see are insatiable, so they have no off valve, right? So they'll eat and eat and eat. And and if you don't recognize that they don't have an off valve, you're overfeeding them. Some kids are always hungry, so they may eat, and then an hour later they're hungry and they want to eat again, and an hour later they're hungry and they want to eat again. So the other thing is that, hang on. Oops. Oh, there we go. So I couldn't see my slides. So the limits on food are really hard to enforce, because somehow kids can look really cute when they ask for more food, and they can look pretty pitiful when they say, I'm really hungry. And then the other piece is that, our American diet has a lot of processed foods, and processed foods are made to be addicting. And I don't agree with our current DHS secretary, Mr. Kennedy, very much, but I do agree on this that we really should be eating not as much processed foods. And our kids shouldn't be eating as much processed foods. Okay, so with feeding issues, getting a diagnosis of a feeding problem really has to do with history, signs and symptoms, an oromotor evaluation, and a nutrition evaluation. Medical evaluation sometimes includes swallow studies, triple scope, which at CHOP we have something called the Airway Clinic, and a triple scope is where you have a pulmonologist go down into the lungs and see if there's any evidence of aspiration. Then we have an ENT look at their vocal cords, make sure there's no laryngeal clefts, and that the anatomy is normal. And then a GI going down the other tube, the esophagus, and into the stomach, and making sure there's no evidence of reflux. And interventions, I think some of us come into this thinking, okay, your intervention is either tube or no tube. But working with our speech therapist for many years, I've realized that's not true. So a lot of times, when we see kids with aspiration on swallow studies, we're really looking at slower flow bottles and nipples, and something that they will use even during the swallow study to see if the aspiration improves. We could be looking at food and fluid texture adjustment. feeding positions, and then calorie and nutrition optimization, so concentrating formula for babies, and then an NG if they need it, and a GT if they need it. When we're looking at the other range on obesity, so our growth studies that we did at CHOP showed that for school-age children, if you look at the normed BMI, in other words, if you just plot all kids with Down syndrome on a BMI, and this is a BMI, on the right is a BMI chart from the growth charts for CDC, that for kids with Down syndrome on their curve, the 50th percentile was in the obese range for BMI. So we can't rely on the Down syndrome charts to figure out if a child is eating too much and is overweight. So what we do for school age children, and I do it even for younger kids, is I also look at the BMI charts and the weight for length charts on the CDC curves. Okay. Does that make sense to everybody? Yes.
Yes.
Okay. So that should be, and we have had kids get reported to DHS or DFS, whatever you call it in the state of Maryland, the Child Protective Services, because they're failing to thrive on their Down syndrome curve because they're underweight on the Down syndrome curve, but on the regular curve, they're fine. And so, and pediatricians say, oh, give them more to eat because they look like they're falling off the curve, but they're on their Down syndrome curve and they're really just kind of getting more healthy. Okay, and then the other piece is just paying attention to crossing percentiles. So if you have weight that looks like the top, the chart to the left is length on the top and weight on the bottom, and you can see the length is leveling off. This is for a older kid. And the weight is not leveling off on the bottom. Okay. So obesity complications. Obesity creates a lot of stress on joints and stress on energy. And the way I've taken to explain to parents is a 24-pound overweight is like carrying 3 gallons of milk extra. So, try carrying 3 gallons of milk like around the block. The increased risk of high blood pressure, sleep apnea, diabetes type 2, and Alzheimer's is a long-term risk for being significantly overweight. And so this is not just, short term, but really we're looking at, kids who are born today with Down syndrome will have life expectancy probably around 60 or just above 60. So this is when we're treating kids, when we're treating conditions that have implications for adulthood, I think I'm very conscious about really needing to emphasize that this is something that's not just for today, it's something for their lifetime. So, we usually get a nutrition consult. We do have a healthy weight program at CHOP, but it has a long waiting list. We try to limit time and place for eating. So no food around or food locked up if you need to. And we have a lot of refrigerators that have locks on them at home. A trick that I've learned from a lot of my parents is half portions at restaurants. So they just get the waiter aside and say, whatever you give to him, just half it, and then put the other half in a doggy bag to take home. Smaller portion sizes that you serve, so that you're serving the food, not they're serving the food. And then milk or water, but trying to avoid juice and soda or making that a special treat. Okay. Moving on to GI issues, including constipation and GERD. The key cause is GI dysmotility. And the dysmotility occurs at every section of the GI tract. So on the right is you can see the esophagus going down from the mouth to the stomach, and then the small intestine, then the large intestine. And all of this, the GI tract is smooth muscle with several neural networks controlling the smooth motility of contents from one end to the other. And so that just like the nervous system in the brain doesn't work quite as well as it needs to, it's the same in the GI tract. In DS, motility is not so smooth nor coordinated. And so you have issues with reflux and issues with constipation are the two most common things. The guy on the right is one of my favorite patients, and he had just motility like crazy. Still does, actually. So gastroesophageal reflux. So studies show about anywhere from 14 to 40% of individuals with Down syndrome have issues with GERD. It's in some studies, it's over 50%. And in GERD, of course, I mean, many people know what GERD is, right? Usually I don't say GERD, I say heartburn. And when I say, like heartburn, and then inevitably one of the parents says, oh my gosh, I have horrible heartburn. It's horrible. It's horrendous. Causes pain in the stomach, the lower sternal area, the chest, and the throat. And I find more success asking kids if they have pain in their throat, sometimes pain in their chest, but rather than pain in their stomach. It causes, especially in babies, arching and irritability in any age. It can be the source of maladaptive behaviors. So there's another syndrome called Cornelia de Lange syndrome that has horrible reflux. And they were known for horrible self-injurious behavior in the first year of life. And when we figured out that it was a lot of reflux and we started treating the reflux, self-injurious behavior is no longer a hallmark of that disorder. Aspiration and hoarseness. If we always think of aspiration as difficulty swallowing and food going into your lungs from above, but reflux also comes up to that level of your throat and can go into your lungs. So, and that's what causes the hoarseness. The hoarseness is the inflammation that's caused by the reflux. It causes food refusals. So, if I have a child who's tantrums and the parents say, I say, when do they tantrum? And they said, whenever we put her in the high chair. I'm like, well, I guess there's a reason, and looking for and treating the what I assume to be reflux because it's painful to eat. Strong preference to preferred foods, or also predisposition to wanting a bottle because that's kind of the most comforting way to drink. And poor growth we can see. And then long-term reflux causes scarring in the esophagus or can cause scarring and esophageal dysmotility and strictures, which aren't uncommon in adults. So that's the other reason to treat reflux. Okay, I'm not going to go into this because it's just, I think you can get, all these different probes and things like that, or an endoscopy looking for damage from reflux and long-term effects of reflux. And treating reflux has to do with medicine, both for motility and for reducing the acid in the stomach. Sometimes surgery in babies if their reflux is so bad. And then generally feeding directly into the stomach or past the stomach sometimes is needed, especially if we think they're that they're aspirating. Okay. Second GI issue, constipation. So constipation is, I wouldn't say universal, but probably affects at least a third to a half of patients, at some points. Um, and what causes constipation is, liquefied food. Remember that diagram we saw before, enters the colon as liquid, and then the colon absorbs water and gradually stools firm up. But if that processed food the sits too long, it gets more and more water drawn out, and then the stool gets harder and harder, and then it's difficult to move more solid stool through the colon, and it gets harder and more painful to evacuate that stool, and that leads to impaction. So, and I don't know, I'm sure many of you have seen the Bristol stool chart. But we use this a lot with families to explain that type 4 and type 5 and even type 6 is what we want. And 1, 2, and 3 means that you're constipated. Okay. And you need some help either with your diet or with laxatives or both. This is just I'm not a very good drawer, as you can see, but this is the way I explain it to parents is that, when you get constipated, you get food backed up into your colon, and when it gets backed up into your colon, this nice ring of muscle on the right gets stretched out, the nerves get stretched out, and all that muscle doesn't work very well when it's stretched, and the nerves don't tell you when you're full and when you need to poop as much. And then you get backed up, um, and the liquid the liquid food that's coming through, because you're still eating, is seeping around and sometimes coming out as what looks like diarrhea, several times a day, but it's not actually diarrhea. It's just that you're impacted and you have leaking. Okay. Um, okay. Diagnosis of constipation. I use physical exam primarily, and I do a lot of percussing of abdomens, which means, I don't know if you guys know what percussing is, but it's kind of like when you look for studs on a wall, you're looking for sounds that's more solid rather than empty, which it should be mostly, your stomach should be mostly air. And so should sound empty. Sometimes people will use x-rays, sometimes they'll do ultrasound, and not very often these days, but sometimes a rectal exam is done. But mostly physical exam, symptoms, and signs. Okay. Treatment, you have to get things cleaned out first before you can work on getting that stretched out bowel more in shape. Regular toileting times, and then squatting positions on your potty or your toilet is really important because anatomy, that's the way you're anatomically going to release best. Okay, and then the fifth, I think, medical condition we see a large amount is sleep apnea. 30 to 70% of individuals with Down syndrome have sleep apnea, often is asymptomatic. Symptoms can be various, but many kids don't have obvious symptoms of sleep apnea, which is why we do get a lot of sleep studies. But restless sleep, snoring, pauses in breathing, daytime congestion, frequent awakenings, hard to get up, needs more sleep, and daytime fatigue. And if I hear kids snoring when they're awake, meaning they have really loud breathing, I'm always getting a sleep study. And we've had sleep studies that show pretty severe apnea with daytime congestion. So interventions, tonsillectomy, adenectomy, nasal steroids and cetirizine or another antihistamine if it's mild. CHOP is on a study now looking at whether oxygen can help with sleep apnea, and then CPAP. And then we have this godsend surgery called hypoglossal nerve stimulator. which is approved for kids with Down syndrome 11 and up when you have significant sleep apnea and you can't tolerate CPAP. Okay. All right. What time is it?
It is 7:44.
Okay, and we're aiming to end at 8 or 8:15.
I would say 8. I would say 8:15 is fine because we have until 8:30.
Okay. Okay. Should we open up for questions before I go on to neurodevelopmental, or should we just wait?
We do have some questions if you want to do them first. It's up to you.
Sure. I mean, it's a different shift in topic, so it
Okay.
might.
Okay, so I can read the ones that we have in the chat, and then if folks, I can people can come off mute as well. The first question that is in here is, what is your suggestion for helping our teens with Down syndrome eat less without giving them a poor body image or feeling badly about themselves?
Mm-hmm. Wegovy?
Seriously? Because that's the next question.
Seriously. We are using, so there's a big shift in the medical community, probably in the last 5 years or so. Seeing shift from seeing obesity as a lifestyle problem to seeing obesity as a medical problem. And it's really a huge shift. And it should have happened many, 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 many other years ago. But I think just recognizing that this, there are bodies that metabolize food differently, that assess whether you're hungry or not differently. There's a lot of chemicals in your brain that are different when you're prone to obesity. And so we're recognizing that kids and adults can't do it on their own, right? And I think you saw that some with the surgeries, but now that we have the GLP-1s, it's been a real game changer for many, not for all. How do you? I think that it's probably not blood, but a lot of sweat and tears restricting your diet enough to lose weight from a position of obesity. It's possible, but it's really hard. And it takes almost religious commitment on a 24/7 basis, right? And so I think that and it takes a lot of it's in the army now, right? You just gotta and kids with Down syndrome are rule followers. So if you can kind of what I think some success is with just really kind of getting at very concrete rules about healthy eating. And it's just you're battling again a drive to eat. So anyway, but this is why the Wegovy and company is the game changer, because it's been really, really hard. And we've been asking people to do what's probably for some nearly impossible. Does that answer your question?
Yeah, and I mean it does. And so just a little bit more about the GLP-1s. A question about that. Would you like at what age is that appropriate for in a person with Down syndrome? And then also, even though within the last 5 years it's becoming more of a medical issue, there's a lot of health insurance companies that still will not cover the costs. So what do you suggest in that case? Because I mean, it can be what, $500 to $1,000 a month.
Yeah. So one, I think it's going to get cheaper, especially with the tablets coming out. But and they don't all work, and they don't work differently. So like if Wegovy doesn't work, then Zepbound works a little bit differently.
Mhm.
So the first thing as far as affordability goes, is you have to have a comorbid condition to get it paid for by insurance. So that's the angle that everybody takes. So if I'm seeing a young adult with obesity, who I know has been struggling for a long time, I first thing I get is a sleep study, because chances are the sleep study is going to show sleep apnea. If it has significant sleep apnea on the sleep study, then you're golden, because Zepbound is going to be covered by most insurances. Okay. If you have an elevated hemoglobin A1C, then you have a co-occurring condition. So, and I think with obesity, there are a lot of co-occurring conditions, but the sleep apnea and the diabetes is probably the ones that insurance are going to cover pretty easily. So that's kind of the first thing.
Okay.
Was there another question there?
Oh, there's several questions here. So, so I'm going to just keep going. Does minor reflux in teens or youth with Down syndrome often grow into GERD, or is that just predisposition?
So GERD, so the difference between GER is gastroesophageal reflux, which we all do sometimes, right? Any wet burps, that's gastroesophageal reflux, okay? Heartburn is gastroesophageal reflux. GERD, what makes it the disease is the inflammation it causes, or the impact it has on your eating and growth, right? And the reason we use the reason we use Pepcid and omeprazole and Nexium, et cetera, is to reduce the acid in the stomach. So when it's coming up, it's not as inflammatory. Okay, because it's the inflammation on the esophagus that we worry about, because that can cause scarring. It can lead to predisposition to esophageal cancer, but it could also lead to scarring and strictures. So it's not uncommon for adults to have strictures, and food's getting stuck. You can see that sometimes in older kids, but that's the reasoning behind it. The other reasoning behind it is that if you have reflux and you aspirate, it probably causes more damage than just food from above, right? Because it's acid into your lungs. So, yeah. So I think, and so the flip side of it is that it comes and goes sometimes. But if so you treat it for a month or two, things get better, you stop treating. If you get symptoms back again, we keep on treating with the omeprazole and those are the PPIs, Nexium, omeprazole, Prevacid. You need to get bone scans, because it can lead to fragile bones. So if you've been on them for a while, we get DEXA scans on individuals.
Okay, that's good to know. Thank you. Would you recommend repeat sleep studies on kiddos who had normal sleep studies a few years back, but if now having more restless sleep and frequent awakenings?
So it depends partly on their exams. So if they have large tonsils, yes. If they have lots of what sounds like nasal congestion, it may be adenoids. And even if they had the adenoids out, they can regrow, then yes. If they have gained a lot of weight, then yes.
Okay, thank you. What is the youngest you can start something like Wegovy?
I don't have the answer to that. I know we use it in teens quite a bit. I don't know how young our healthy weight clinic has gone down to.
Okay. What do you think about or think of home sleep studies?
Love them. We just did a study at CHOP showing that they are accurate. They reflect what's going on in the lab. insurance still's not paying for them.
Right, until you're 18, I think, something like that I
Yeah,
saw.
and you have to be careful because the studies that we did, the home apnea monitoring, were top of the line. So I would expect that they're going to be cheaper than sleep studies, and they're probably going to be more reflective of natural sleep if they're done at home. But they're not going to be inexpensive because really you have to have really good equipment.
Thank you. And then what is your thought, or what are your thoughts on probiotics and how safe are frequent laxatives?
Okay, so probiotics, fine. There's nothing wrong with them. They've not really definitively showed that they help with constipation, but some people swear by them. So, and if I eat enough whatever that yogurt is with all the probiotics, I know that works. So, but they won't hurt you. And especially after antibiotics, it's a good idea. So if your child is on a lot of antibiotics, I would say probiotics, either after or while they're taking antibiotics is a good idea. For what was the other question?
Oh, about how safe are frequent laxatives?
So laxatives are not addicting. Please tell that to everybody. Laxatives, so there's laxatives that women used to take because to lose weight that basically just kind of speed everything through and anyway, those really weren't addicting, but they whatever. Women overuse them, men overuse them when they're wrestlers and people like, the in those situations. But um if we have many kids that are on laxatives for their whole lives and they will be on laxatives for their whole lives because their gut does not move in a coordinated way, right?
Okay.
And if they stop their Miralax, if they stop their Senna, if they stop their milk of magnesia, um, they stop pooping, and no matter what you do with their diet and everything else, just so don't worry about if your child is on laxatives and they've been on laxatives for years. They're not going to be addicted. Okay. Um,
Okay.
so stronger laxatives like Dulcolax is probably one of the stronger ones. And I do have some kids that have to be on Dulcolax, even that's the only way they poop. But Dulcolax is a good one to have in your pocket when you haven't gone for a few days, and you really need to get things out. It's more effective than Miralax, more effective than Senna. So, but it's not something that we use unless we really have to every day.
All right, great. And somebody did comment here. One of our parents said that she thought that FDA approved the GLP-1s for 12 and older, but
Okay.
she'd have to double check. And then here, following up on sleep study question, if the answer to your physical exam questions are all no, like no enlarged tonsils, no enlarged adenoids, no weight gain, but you're seeing a huge spike in night waking during puberty, thoughts about which specialist to work with on figuring out cause and solutions. Like for preteens, sleep studies are to obtain and all three over the years have shown no apnea, so an additional sleep study will be tough to get.
Yeah, I mean, I don't think if you've had several normals and your weight has not changed and you're still is your BMI hasn't changed significantly, there's probably something else going on. And so I think speaking with speech, a sleep specialist is a good idea. Because there's a lot of things that interrupt sleep. So I have kids that slept marvelously after, for example, Prevacid at night, right? Because reflux is waking them up, and they're miserable. I've had kids do miraculously on singular and nasal steroids, or Zyrtec, or is the other Zyrtec, levocetirizine. because it's the upper the nasal congestion that's causing them to wake up. So, you know, there's other reasons. You want to make sure if it's depending on who it is and what's going on, sometimes seizures can do it. So, you know, you can have anyway, so it's important to consult with this I think with a sleep expert if it's not obvious. You know, some things are obvious too, like sleep association. So kids don't sleep well because they go to sleep listening to their whatever video screens or phones or whatever. And then when they wake up and it's not on, they need it to go back to sleep. Young kids, if you put them to bed and lay beside them, they need you beside them again when they get up, as everybody does, in the middle of the night and can't put themselves back to sleep. So,
Great. Okay, so um, there's two questions here, and then we're going to move on. So we have read of behavioral challenges using, and I'm not sure, Carrie, what PEG specifically stands for.
okay. So
Yeah.
so Miralax, I don't like Miralax, for a lot of reasons, but there's nothing about it that's natural. Nothing. And there have been listed as, so when it was approved by the FDA, it said no longer to be used no longer than a week or a month or something. It was, you know, and we have kids on Miralax for years. The reason it's called Miralax is because when it first came out, it was a miracle laxative. Okay, so you know, there goes clever marketing. And everybody, like I moved from West Virginia to Philadelphia. I was a general pediatrician in West Virginia. And West Virginia, I exclusively used milk of magnesia for all of, I had lots of constipated kids, but I was trained by somebody who used milk of magnesia. So that's what I used. And I came up to CHOP and everybody was like, I was like, what is this Miralax stuff? Because everybody was on it and nobody was using milk of mag and nobody was using enemas anymore and stuff like that. So I was like, oh, I'm in a new world here, but I still don't like it. So, and generally, like our GI docs are going back to using more Senna. They're going back to using more milk of mag. They're going, and then there's other things that are here now that we're starting to use. Linsness is one of them. Linsness. But there's no, in other words, they're starting to use more motility medications to treat constipation, which I think is a good thing too. So, because motility is the source. So,
Great, thank you. Okay, so the last one here is there a correlation between Down syndrome and Cushing's?
not to my knowledge.
Okay,
If you have
well then,
Cushing's, it's probably not related to Down syndrome because I've never seen it and I've seen a lot of kids with Down syndrome.
great. All right, let's move on to neurodevelopmental and behavioral conditions.
Okay. So, why do neurodevelopmental and behavioral conditions co-occur? So, one, the brain of kids with Down syndrome or fetuses with Down syndrome develops starting differently starting in the womb. So if you neurogenesis, meaning the genesis of the neurons, the beginning of the neurons, the birth of the neurons, but it produces fewer brain cells in individuals with Down syndrome, and thus you have when you look at, say, an MRI. You have thinner cortex, which is the outer gray layer of the brain. And the folding of the edges of the brain is less complex, so it's just not as well developed and as complex, just the anatomy of the brain itself. And then connectivity differs. So information processing is done through connectivity in our brain. And in individuals with Down syndrome, there are fewer cells that produce myelin. Myelin is the sheath that is if you think of, like, I don't know, computer cords, phone cords, right? And they're wrapped in rubber. Okay. So myelin is that rubber. Okay. And it serves as insulation. It also serves to make the electrical impulses that transmit energy, transmit information from one cell to another. it makes it more efficient. And that's referred to as the white matter part of your brain. So the speed and efficiency of nerve transmission is altered, and then there are fewer connections between nerve cells. Okay, so your nerves, one nerve connects with fewer nerves further down, wherever they're connecting to. So it's like this, if you look at MRI studies, there's some MRI studies that show all these connections, and it's like, if you ever look at like highways in like DC, or they're like all these coming together and overlapping and blah, blah, blah. And the brain is like I don't know, that on steroids plus plus. Okay, it's just got huge numbers of connections from one part of your brain to the other. All right. So, rather than going into every single neurodevelopmental issue, I just wanted to bring up the five, six, seven biggest things that we see. And speech and language impairment, communication disorders in general, speech apraxia, autism spectrum disorder, ADHD, anxiety and depression, and then just to add, because this is a hot topic, DSRD, which we won't talk much about. So communication. So most, our communication with each other, we forget that some people say 70% of interpersonal communication is nonverbal. Okay, so eye contact, facial expression, gestures, body language, intonation of speech, and the rest is language. So less than 50% is language. And the coordination of all forms of communication are important for interpreting meaning. Okay, so if you're and individuals with Down syndrome tend to be kind of what Trudy Fulmer, who was an educator up here and had a daughter with Down syndrome, said was single track thinking. Okay, so you're concentrating on the eye contact, as you could tell probably with babies, right? And their eye contact is right on me, and I'm ringing a bell, and they're totally ringing the bell, right? So when you have that kind of thinking, trying to keep track of eye contact, facial expression, gestures, intonation, and language is challenging. And we all do it very naturally, and as do our kids with Down syndrome, but with kids with Down syndrome, it's just more challenging to put all that together and get together quickly and efficiently. So speech and language, in kids with Down syndrome, receptive vocabulary is usually good and at the same level as their nonverbal skills, okay? What's more difficult is grammar, processing time, working memory is harder. And working memory means how much can you keep on the screen at once, okay? Because like if you think of your brain as a computer. So, if you tell your child to do, say, 3 things or 4 things, or we're going to do this, 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 and this, right? Working memory means they could maybe keep 2 of those things on board. And if something else comes on board, something else has to leave. Okay. Expressive language is more difficult. And what makes expressive language more difficult, one is intelligibility. And on the level of articulation, so certain sounds are harder based on their muscles, their anatomy, and articulation is kind of an anatomy-based difficulty. And then coordination of speech or apraxia is more a brain-based coordination issue. Okay, how all the parts of your brain that's needed to produce a word or a sentence come together. And then the other part of expressive language is language-based. Okay, so when you use language as effortlessly as most of us do, we're doing word finding at an incredible speed, right? But word finding can be difficult if you and less efficient. Building multi-word utterances, so being able to put all these words together, and then putting ideas together in ways that make sense. Okay, and that's a skill called building narrative. So building a story or building narrative through conversation. Okay. Effective communication is key to social, academic, and vocational pursuits. Okay, so after nutrition, I would say speech and language and communication is the thing where I put my money. Okay, so when parents ask me, what do we want to work on? I say speech therapy, speech therapy, speech therapy. And if you're not getting it at school, don't wait till school is going to fill the void. Go get it privately through your insurance, or if you can afford it privately through self-pay. And when we talk about any kind of therapy, we talk about remediation, which means working on the components of language itself. So targeting specific area of need, for example, articulation, making yourself clearer, or in apraxia, there's specialized interventions with speech therapists trained in apraxia. If you want to know more about that, apraxiakids.org is the website and the organization to go to. And then accommodation means getting around it. So getting around the disability, okay? And so, we don't want to wait till our kids talk clearly before we can say, they can express themselves. So, this is why we tell all kids, all families, all babies to learn signs, because their speech is going to probably be delayed. And we don't want them to get frustrated and use behavior to communicate. Certainly, next to signs is visual supports. So, using picture exchange and visual schedules and pictures to help explain to them what you're talking about, and for them to explain to you what they want to say. And then finally, augmentative communication, which is all the AAC devices that are out there. So diagnosis of speech and language issues. I mean, I think all kids should get a thorough speech and language evaluation. And a thorough one, a thorough speech and language evaluation is about 5 or 6 pages long. We have, and our speech and language therapists are doing a much better job doing thorough speech and language evaluations at CHOP. But I would ask around in your community for the best ones. Intervention, so speech therapy at school and privately. Most insurance pays for speech therapy because old people rule in terms of what gets paid for, and and old people need a lot of therapy, so kids get therapy paid for. And particularly, I don't know about Maryland, in Pennsylvania, speech, all kids with Down syndrome have Medicaid as well as their private insurance. So Medicaid pays for speech therapy for sessions, even when your private insurance cuts you off. Set aside time to practice skills in the context of everyday life. So speech, especially of something like apraxia, but even talking and language, it takes a lot of practice. And and it takes practice, you have to incorporate it into all aspects of your life. And then asking your speech therapist about how to do that. Okay. The other thing is kids never want to practice, okay, because that's not fun. And so you have to incorporate things in ways that make it fun. Okay. Second, autism spectrum disorders. So this was a surprise for me when I started seeing kids with Down syndrome, because on the first day, like I said, the first day of our clinic, we had 2 patients. The second patient, I was like, oh my gosh, he has autism. And he did. And then, we went from thinking of autism as kind of unusual to thinking of autism as pretty common. And now 1 in 5, sometimes people say 1 in 4 kids with Down syndrome have co-occurring autism spectrum disorder. And what spectrum means is there's a spectrum of severity from mild to severe. Children with autism have varied abilities and needs. And a common saying, if you've met one child with autism, you've met one child with autism. And that goes for Down syndrome too, or Down syndrome and autism. And neither autism nor Down syndrome define the child, but they do help explain their thoughts and actions and often give a direction for skills building. So I think it's getting less now, but when I first started, uttering the word autism was like a death knell to parents. And it was really hard to accept a second diagnosis in addition to Down syndrome. I think now that I think there's a lot more accepting, and a lot more embracing the treatments that go along with autism for kids with Down syndrome. So children with Down syndrome and autism. Uh, so many kids, this is a stereotype, but one of the stereotypes that often is true. Many kids with Down syndrome can be sociable, and many kids with Down syndrome and autism are sociable. And I have so many kids with Down syndrome and autism that are the mayor of their school. So when I tell them that their mayor has autism, they're like, whoa, wait, what do you mean? They make great eye contact. They have wonderful self-directed communication. They're constantly saying hi. They often know everybody's name. They're sensitive to others' feelings. When they see somebody crying, they start crying, or they go to give them a hug, et cetera, et cetera. Okay. However, okay, so the things that we see in kids that are these mares, there's what you miss. There's a lack of reciprocity. So they have a lot of self-directed communication. That's really great quality. Making eye contact, smiling, but it's very self-directed, and when somebody says something to them, it's not always reciprocated. So a lack of response to what others say to them, and the way I describe it is that there's got a lot of I draw out an arrow, a one-way arrow, and say, your child has a lot of one-way arrows of communication to lots of people, but they're not developing that circle of communication, which means one arrow and then the other person responds, and then you respond to what they're saying, and you develop these circles of communication, and we don't see that. Often you see a difficulty with cooperative play. That in play with other kids, there's a lot of direction. You do this, you do this, you sit here, and being the boss. And then there's a lot of what self-direction also means is my way or the highway. So kids on spectrum often have difficulty seeing things from other people's point of view. And if you don't see things from other people's point of view, then why shouldn't everything be your way? Okay. Children with Down syndrome and autism often can be very close observers of what's going on around them, and can be really great mimickers. So they mimic actions they see, they mimic signs, they mimic behavior, they mimic words, sometimes understanding, sometimes not. A lot of our kids with autism and Down syndrome can recite whole episodes of their favorite shows and what is the word? Not relive, replicate in their play these episodes. They can pick up signs and words really well sometimes, but still use behavior instead of signs or words, even if they know the words or the signs. And words and signs initially sometimes are used to label or for what they want, but just not really to be social. Okay. So a diagnosis of autism, basically one, we rely on history from family, from school, from daycare. And we're often diagnosing older kids as well, and sometimes adults. We observe their interaction in our clinic spaces. We have, like I said, OT and PT, our nurse, our social worker are also going in and observing and seeing what their interaction is like. And then if we suspect autism, depending on what level of diagnostic certainty is needed, we might do an autism diagnostic observation schedule or an ADOS, a childhood autism rating scale, or an autism diagnostic interview. Those are our three major diagnostic tools. Why diagnose autism? So one is it provides, the main reason is it provides a different perspective on presenting behaviors. So it's almost like you put on different glasses in looking at behavior. You identify behaviors as skills deficits. So in other words, it's not just he's deliberately hitting or aggressive or self-injurious because he wants this. He's doing that behavior because he doesn't know what else to do. He hasn't been able to learn what else to do from just watching other people around him, which is how most kids learn. And then finally, provides meaningful change and intervention. So there's structure and environmental supports that are needed. Sensory interventions, because kids with Down syndrome and autism can be greatly overwhelmed by sensory inputs or can be overwhelmed by the seeking of sensory inputs. Autism treatment involves a lot of skill building involving communication and a lot of skill building involving social perception, social engagement, interaction. And then also, for whatever reason, you often need to motivate kids with autism to do things that most kids just do without much motivation. So things like getting dressed sometimes or toileting or basic stuff like that. You need motivation, and that's part of what ABA does. Okay. And then next steps after diagnosis, it in many states allows for a requirement that insurance pay for behavioral intervention. Educational classification sometimes helps in terms of getting the right supports in school. And then private therapies of OT speech and social skills can get paid for by insurance. And then finally, you have a whole other group, like some of my families say, oh my gosh, you mean I'm not part of the Down syndrome world anymore. I have to be part of the autism world. And it's sometimes hard to be part of both because children, a lot of families kind of shy away from Down syndrome support groups because it's not always easy for their child to engage and interact in those groups. So, but also, we probably do the most advocacy for kids with Down syndrome and autism in terms of educationally because they need more than just the life skills environment, and they need a lot more support than that. Okay. Finally, just really briefly, catatonia or Down syndrome regression disorder is something that we see quite a bit of in our clinic, not because it's that frequent, but just because we're known to treat and evaluate. And this is a neuropsychiatric disorder, which is a combination of elements found in neurologic disorders and psychiatric disorders, meaning it has neurologic components, but also psychiatric components. Catatonia is more common in kids with Down syndrome, other genetic disorders, autism, depression, bipolar disorder, and schizophrenia. So it's not just Down syndrome regression disorder slash catatonia isn't unique to Down syndrome. And I see it in just kids that we see generically with autism in our clinics too. And then parents are often the first to suspect catatonia, but they often need to convince others and gather information and seek out expertise because, and we have kids that have had catatonia for years that nobody's recognized. It's really a tough situation for parents to find the right people. Um, we use Bush-Francis rating scale for catatonia, but there's also a pediatric rating scale. The difference with pediatrics and then with Down syndrome is things we see withdrawal, but we see a lot of social withdrawal. Classically, you see refusal to eat or drink, but I think it's often refusal to socially interact as well, and not always refusal to eat or drink. Incontinence, so kids that have been continent before, automatic compulsive movements, schizophagia, which basically means disorganized and incoherent speech, grimacing and other mannerisms that are unusual, psychomotor retardation, just being really slow in both your thinking and in your movements. Regression in ADL, so no longer caring about dressing, feeding, toileting, or hygiene. Regression in speech, anhedonia, meaning not seeking pleasure in things you used to get pleasure from. Withdrawal in their own, often imaginary world. Responsive to external stimuli in that world to the exclusion of others in their immediate world, and then can be briefly back to normal. For example, we've had kids. One girl I remember in particular talking like just totally catatonic, not really paying attention to anything, and then got her brother on the phone. She says, "Hi, how are you? Yeah, I want pizza tonight, blah, blah, blah." And then hung up, and she went right back to being more of her catatonic state. So it's sometimes can be very confusing. Evaluation talked about, and we do a lot of evaluative workup. Treatment, lorazepam, and second ECT, sometimes other medications, and then IVIG is one of the treatments that some in the community are advocating for in the Down syndrome treatment community, and we do some IVIG with certain indications. So anyway, so that's really a brief kind of my top 10 or 15 co-occurring conditions that we see the most in our clinic. And this is again just from our buddy walk, some of our older kids. And I just put a list of resources. Oops, not there. General resources for Down syndrome. I wrote the chapter on Down syndrome and other trisomies on the in Nelson textbook of pediatrics, which your pediatrician probably has access to. Autism Speaks and has a special Down syndrome page, and the Down syndrome autism connection, visual supports, which are good for all kids with Down syndrome, not just kids with Down syndrome and autism. Encouraging of social communication, whether you are, I think this can be again also for all kids, not just for kids with Down syndrome. And then these are autism specific therapy resources and different resources on understanding autism. Questions? What time is it? Oh, it's 2 minutes till 8:30.
Sorry, I was muted. If you want to stop sharing so we can see everybody, that would be
Yep.
great. And then I have some questions that are that people have asked in here. One is, do you see any impact of diet on speech or communication?
No. So the link between the only link would be that often kids with apraxia, not always, but often, have had difficulty with learning to chew and to swallow too. Okay. It's coordination, so it's central.
Okay. And then how does a formal autism diagnosis benefit a child with Down syndrome who, for example, already qualifies for um, for an IEP and Medicaid?
So uh, we've known through the past 30 years, there's been a lot of work on autism intervention. And there's a lot of expertise on how individuals with autism, how their brains work, but also how they respond to things. So Teresa Bollock, Bolick, it's on my list, but she wrote a book called Asperger's Syndrome in Young Children, which um, uh, but what she talks about is this pyramid, and the base of the pyramid is sensory. And if you can't get a hold of your sensory world, if you can't regulate, right, then it's hard to develop all the other things you need to get along in the world, to learn both whatever you need to learn, but also learn socially. That's one thing. I think that if a lot of kids with Down syndrome have sensory issues, but kids with autism and Down syndrome have significant sensory that needs to be addressed, even before anything else, right? And so I think that's one thing is just recognizing that. So, for example, in a classroom that's overstimulating, right? So many MD classrooms, for example, might be, some kids are yelling, some kids are whatever, and it's really hard for somebody who has sensory issues to get along in that classroom. So they may be just hiding in the corner the whole time, right? And until somebody recognizes that, like gives them some headphones maybe so that the sound isn't so bad, or recognizes that they need a quieter environment, that they need breaks. From a sensory standpoint, that's one. From a social standpoint, like I said, many kids with Down syndrome and autism are really keen on social engagement and interaction. They want to be a part. They love getting tickled. They love that engagement, but they don't know how, right? And so they get tickled, they love it, you stop tickling and they walk away. And you're like, whoa, wait, you love this, right? But they don't know how to access and continue that. Okay. So from a social standpoint, those kinds of basic social reciprocal play things need to be worked on. I mean, but you don't learn socially unless you have that kind of engagement, right? So you need to figure out how to get that engagement, and then how to go from there to then, okay, well, then how do we then get you to say hello? Or how do we then get you to do this or that? Okay. But it's a skills deficit. It's not that they don't want to interact with other people, it's that they don't know how. And then the third thing is motivation. And some kids with Down syndrome and autism have like very little motivation, and so they're just happy in their own worlds. And those are really hard to gain to teach. So I love seeing kids with autism actually who have self-injurious behavior and aggression and tantrums, because that they're motivated to get what they want. Right? And if they're motivated to get what they want, then you need to teach them how to get there what they want appropriately. Okay? But they need to be motivated to do that. So, and that's what ABA is all about, is like, from the very start, like just a picture, a PEX. I know you want the video on, so you have to give me this picture. Okay, you gave me the picture, good. You get the TV on for just a second, and then it goes off again. You have to do it again, and then you have to pick from 3 things, and then anyway, so it's just different ways of teaching. And I think if you don't know that they have autism, you're more likely to think that they really don't have many skills at all, and underestimate what they can do and what they could learn.
Thank you. That was my question. And I have an 11-year-old who has Down syndrome and I suspect autism, but we can't find any provider that can diagnose him with any in-network, and without years of wait lists. And we also have another autistic child with a very different variety of autism. And it is an interesting thing to kind of go, well, but what are we missing? What are we fighting for when we have, we have a whole sensory room for the kid. That piece is there. So, but I appreciate the thoughts.
Thanks, Carrie, for sharing that. Um, do you have a couple more minutes, Dr.
Yeah.
Pippin? Or okay. So and just for folks, we understand that it's 8:34, and if you need to go, we're not going to hold you here, even though this is really super interesting. But make sure, and I put it in the chat, to fill out the evaluation form. We really do rely on them. But one question that actually I have is in a parent meeting last week of parents who have transitioning youth and adults, so 14 and up, we all kind of, I don't want to say admitted, but we came to the understanding in our conversations with each other that a lot of our teens and adults are kind of seeking that conversation, like a back and forth conversation with either their typically developing peers or somebody else who has an intellectual or developmental disability but can carry a conversation in a much with greater ease. And so one of the questions that we all had, well, gosh, what can we do to really encourage that back and forth conversation for those of us with or without autism, um, to ensure that that inclusion happens and that ability to converse is highlighted and is practiced. And is there anything that you would suggest for parents of, kids or adults with Down syndrome of those ages, or even younger, to practice it as they're younger as well?
So I think auditory information alone is hard to process, sometimes for anybody, right? Like if you think about, or if you think about if you're trying to process information in language you don't know very well, right? So I usually say to that you in a conversation you need visual supports. One, to keep on topic, and two, to let everybody be. So, conversation is a lot about joint attention, right? Like if I'm talking about, oh gosh, the last series I saw, Scarpetta with Nicole Kidman. Okay, not recommended for anybody who doesn't like, gory stuff. Okay, but anyway, but like I'm talking about that, and immediately several people know kind of they're zeroing in on what we're jointly have in common, right? We're doing that without any visual, we're doing that without anything, we're doing that totally through our brain, right? Through our thinking processes. That's really hard for kids with Down syndrome. Okay. Plus there's a language barrier. So the rate I'm talking is way too fast. Okay. And if you have a child who has like 4 to 5 word sentences, that means that 10 word sentences are not going to get processed the same way. Okay. And so what I encourage parents to do is to you can do this through your augmentative devices, or you can do this through just like a photo album. Like, when you go to a family event, bring a photo album of an event, or having a little like mini photo albums of my week at the beach, my English class, my field trip, right? And so that you have a visual joint attention, so that keeps your child on track. But it also, if other people have difficulty understanding them, when they have a visual in front of them, it's a lot easier, right? Does that make sense?
Yeah, no, that's actually really interesting.
And I think that's also helpful because conversation, people don't understand this, but conversation is building narrative between two people, right?
Right.
Okay. And building a narrative requires you to have kind of like an idea of what's going on in a sequence of events, right? Okay. And so the other thing that our speech therapists will do is help kids build narrative, because they can't have a conversation unless they can build narrative. And so building narrative might be something like a series of pictures or words, books without words but still have a story. And working on that skill, okay, because it's really hard, I think, for kids with Down syndrome to do that without something concrete.
No, that's super helpful. I'm just also reviewing more questions here. Well, I mean, I don't know if you've been looking in the chat or not, but everybody is very just so helpful. This is great. And, we found visuals are huge for helping our son do the narrative building. Let's see. And then just some information, hearing and speech at Gallaudet has a speech therapy group for adults with Down syndrome. And then lots of thank yous for starting the conversation. It can be very helpful to everyone, since our individual, let's see, bodies are so complex and beautifully different, and we want to help our sons and daughters develop to be the best they were created to be, and help them appreciate their own bodies and appreciate each of their friends, and as they grow into adulthood. Oh, and then, here's one. Can CHOP do telehealth in Maryland?
No,
So
that's
you have
kind
to
of a
come all the
national.
way to Philly.
I mean, I think if COVID lasted a little bit longer, we might have gotten some laws that said that you can do that insurance would have to cover cross state lines, but unfortunately, the local I know it's just complicated, but someday, yes, probably, but not yet.
Um, is CHOP, is it through 18 or 21?
So, um, it's through whatever. We're mid 20s,
Okay.
some 30.
Okay.
When we don't have at this point, we don't have an adult doctor, so we let some 30s to 40s runs come through if there's really cogent reasons to seeing them. But um, really, I would say through early 20s. The difference between 21, 22, 23, and then 27, 8, 9 is that I don't prescribe for, I try not to prescribe for adults because I'm not an adult physician. So,
Mm-hmm.
in my younger kids, I do a lot of therapy, not psychotherapy, tropic medicine. Like I'll prescribe, for example, kids with catatonia. I'll prescribe their Ativan, but um, not as comfortable with that as they get into adulthood.
So, yeah, and when you're talking about catatonia and Down syndrome regression disorder, and we certainly have had several families within our own community who've teens and young adults who have been diagnosed with Down syndrome regression disorder. And and I know that Dr. Capone here at in with Johns Hopkins does adults, but he's retiring. So I'm just wondering,
Yes.
Um, do we have to go all the way to Denver?
Um,
Where
well,
there's
I
the
think,
big or
Kennedy
California?
Krieger, Kennedy Krieger has for pediatrics anyway, and they go through 21, 22. But
Mhm,
Kennedy Krieger has a number of psychiatrists who are very well versed in Down syndrome
mhm.
and catatonia. Um, what you can't get in Baltimore anymore is ECT. We had a psychiatry connection who just moved to Northern Virginia. At Hopkins, and she said there was just not, it wasn't there. Um, so, but at any rate, but yeah, Kennedy Krieger would be the place to go.
Yeah.
I know they have a huge wait list,
Oh,
but
I meant Kennedy Krieger. I know I said Johns Hopkins. I meant Kennedy Krieger.
yeah, they're
Sorry.
associated with Johns Hopkins, but yeah.
Yeah. Well, if there aren't any more questions, this has been fantastic, Dr. Pippin. We really appreciate you coming and sharing. I've written so many notes, and I know that people are wondering. Yes, we will have the recording of this session and share it with our group. And there's lots of comments, not necessarily questions. However, there's lots of information also that people have shared in the chat, that people are welcome. If you're not reading it, everyone, you should, because there's information about other doctors in the area, and this is great. I'm going to be saving the chat.
Mhm.
So thank you all very much. It's so
Okay.
nice to see everyone here.
All right.
What a great group. So thank you so much, Dr. Pippin. We really appreciate it.
All right. Take
Thank
care.
you and
And
have a
if you
wonderful.
have, if you have significant issues, we do see kids out of state. It just takes some finagling to get insurance approvals.
Yeah.
So, but we do have a few kids from down your way and Virginia that come up. So,
Right. It probably depends on the health insurance policy.
exactly.
Yeah.
Yeah.
Thank you.
Okay.
So helpful.
Thank you so much.
You're welcome. I'm trying to figure out where the off button is.
Oh. Oh, I know. I haven't ended it yet because I'm reading the chat and I'm writing down some doctors' names that some local folks have mentioned. But all you have to do is click leave, I think.
Got it. I found it.
Okay.
All right. Bye, guys.
Thank you so much.
I'm just gonna say hi, Brooke.
Hi, Carrie. How are you? I know. I'm like, oh, Helen just is over here.
Yeah.
She's been very patient over here because Mark's not home tonight. So I'm like
Patience.
in her pajamas even. All right. So I didn't know that Dr. Capone was doing a 40s and older DS clinic, but I don't know if he's doing that somewhere else. I'm gonna write this down.
Oh.
No, we've got Carrie here.
Hi, Helen.
Oh, look, and here's Gina, Miss Gina Gueco. That's she can't see you because you don't have your picture up. Look, and there's Ethan's mom, Shannon. That's
Brooke, I'm in
mom.
the Philippines, so it's
Oh, you're in the Philippines. Oh my gosh.
so it's AM here of Thursday.
Oh my gosh. Is
PA's
Tia with you?
yes, PA is here.
Oh, hi, Pia. Look at
Hi
your
to
cute haircut. Helen, here, you want to say hi to Pia?
There's Helen.
Oh, I
Say hi.
love your haircut. It looks so good.
What age?
How old is, I don't know how old, I don't know how old Pia is, but that's not like the first thing that you should be asking.
She's older than you.
Yes, she is. She's older. She's in her 20s, I think. And I don't,
One.
I don't know.
Thank you
how
for
long are
having
you're in there?
this.
You're there for how long?
Until the 20th of May.
Oh,
So,
wow.
so about a month more, or less than a month. Yeah.
Um,
We'll be there for the picnic.
oh, good.
It's in June, right?
Yep. I think, what did I say? The 13th?
Yeah, I have to look again. But we'll be there
Oh.
in June.
Anyway, so.
Okay.
Okay, thank
All
you
right,
so
well,
much
it's nice
for
to see
having
everyone.
this.
I'm just like, I know I'm just like
Yeah.
putting in here to see what else. Oh, look at this.
Oh, I
I'm
see
still recording.
Shannon.
I'm gonna stop recording.
Yeah.
Like chatting away.